Great. Well, thanks everybody for joining us today. Today I'll be talking about pulmonary hypertension, looking at the guidelines and also a research update on a few projects I've been working on. I have no financial disclosures. Today our objectives are going to be to review the updated pulmonary hypertension definition, differentiate between groups 1 versus groups 2 through 5, describe patterns of pulmonary hypertension in rural Minnesota, and describe our Minneapolis Heart Institute rural experience. And then 4, discuss pulmonary hypertension post-TAVR in our patient population at Minneapolis Heart Institute. So what is pulmonary hypertension? Well, it describes elevated blood pressure in the pulmonary vasculature. Often leads to progressive right ventricular heart failure and subsequently death. In regards to pulmonary arterial hypertension, although it has an excellent 1-year prognosis approaching 91%, the 5 to 7 year survival is only about 58%, which is a poor prognosis. Now, unfortunately, these patients with pulmonary arterial hypertension spend about, on average, 2.7 years from symptom onset to diagnosis. And so they've burned up half of that 5 years already by the time they finally receive a diagnosis and can then start treatment. There's a myriad of symptoms with pulmonary hypertension. Exertional shortness of breath is ubiquitous. Fatigue and edema are also very common, as well as mental health issues that come along with not being able to breathe, with depression and anxiety, very common. Right-sided failure with pulmonary arterial hypertension often leads to bloating, early satiety, and due to splanchnic congestion and sometimes liver congestion. When we look at the anatomy of pulmonary hypertension, recall from anatomy, we all know the right-sided circuit where the right ventricle is connected to the pulmonary artery. And there can be pathology all along this path from the right ventricle all the way back to the left atrium. And so we can see pulmonary hypertension develop in high output states, such as with anemia or nutritional deficiencies. We can see it in different disease states, such as hemorrhagic or hereditary hemorrhagic telangiectasias, or HHT, where arteriovenous malformations may form, increasing high output states. We can see it with protective vasoconstriction that can happen with hypoxic states. We can see it with irreversible plexiform lesions that happen in different disease states, such as pulmonary arterial hypertension. It can also be due to intrinsic left ventricular heart disease, such as with aortic valve stenosis or regurgitation, and likewise mitral valve regurgitation or stenosis. And also with the cardiomyopathies with either non-ischemic or ischemic cardiomyopathies, or heart failure with preserved ejection fraction or diastolic dysfunction, affecting the filling pressures and back pressures within the pulmonary circulation. And then, of course, intrinsic disease in the pulmonary venous circulation, with pulmonary veno-occlusive disease occurring less commonly. When we look at how we classify pulmonary hypertension, they're broken down into 5 groups, and sometimes in some circumstances these groups are very clean and very specific, and in other groups they're left as a kind of a garbage can diagnosis, where the groups within these don't fit as nicely together. So when we look at group 1, we're talking about pulmonary arterial hypertension, or that pre-capillary remodeling happening with intimal fibrosis and medial hypertrophy in the pulmonary arterial arteries and arterioles. And we're looking at the associated pulmonary arterial hypertension diseases, such as with connective tissue disease, like scleroderma or rheumatoid arthritis or mixed connective tissue disease, less commonly HIV infection, portal pulmonary hypertension, the congenital heart diseases with shunts, and worldwide schistosomiasis, which is less common in the United States. And then also within this group is the drug and toxin-induced pulmonary arterial hypertension, or things from things such as methamphetamines, cocaine, and one of the diet drugs, fen. And then, of course, hereditary pulmonary arterial hypertension, which is most commonly associated with the BMPR2 mutation, which accounts for about 80% of those with heritable PAH, and found in families where it can cluster. And then idiopathic pulmonary arterial hypertension, once these other causes have been ruled out. When we talk about group 2 pulmonary hypertension, we're really talking about pulmonary PH due to left-sided heart disease. And as previously mentioned, this could be from either heart failure with reduced ejection fraction or preserved ejection fraction, the valvular heart diseases, and then other cardiomyopathies such as hypertrophic cardiomyopathy. Group 3 pulmonary hypertension is due to lung diseases, so either COPD or interstitial lung disease most commonly, but also seen in chronic hypoxic states such as obstructive sleep apnea or central sleep apnea, or some of the more rare diseases where the lung doesn't develop fully in utero. When we talk about group 4 pulmonary hypertension, we're mainly talking about chronic thromboembolic pulmonary hypertension. And then group 5 is a less clear category that is a grab bag, so to speak, of different disorders, such as the myeloproliferative disorders, like essential thrombocytosis or polycythemia vera or chronic hemolytic anemias, other systemic disorders such as sarcoidosis, metabolic disorders such as thyroid disease, and then other disorders such as tumor obstruction, fibrosing mediastinitis, chronic renal failure, either with shunts or without, and segmental pulmonary hypertension. When we talk about epidemiology and how commonly pulmonary hypertension occurs, we know that it has a female dominant distribution from various registries from around the world and in the United States, and occurs in an almost 5-to-1 fashion from females to males. The idiopathic and heritable PAH incidence is only about 5 to 15 per million, so it's very uncommon, or we're taught in school that it's a very uncommon disorder, a zebra, so to speak. 10 to 15% of patients, however, with scleroderma will develop pulmonary arterial hypertension, and these patients often warrant close evaluation and follow-up with yearly echoes. And the most common connective tissue disease associated with pulmonary arterial hypertension is scleroderma. About 3 to 10% of patients with congenital heart disease will develop pulmonary arterial hypertension, usually in patients with atrial septal defects or ventricular septal defects. And then 2 to 16% of patients with portal hypertension or liver disease will go on to develop PAH. And so those patients often warrant close follow-up and evaluation. When we look at all comers in patients with PAH, the associated pulmonary PAH conditions account for about 50%, and idiopathic accounts for almost the remainder of the 50%. And when we look at the associated PAHs, this white group here accounts for about 50%, or a little over 50%, and this is the connective tissue disease group, accounting for the most, and then congenital heart disease is second most, with toxins and portal pulmonary hypertension accounting for about 10 to 12% of the PAH category. When we look at different referral centers, this is a study published from our Vanderbilt colleagues looking at 246 elderly patients greater than age 65. What they found in looking at 246 patients is that, the majority of the referral population, over 50%, were accounted for by or fell into a group with hemodynamics consistent with either group 2 pulmonary hypertension or a mixed or combined pre and post capillary pulmonary hypertension. And when they looked at this, out of proportion pH was typically related to groups 2 or group 3 pH, either due to left-sided heart disease or to COPD. And then about 36 patients of their 240 or so patients fell into a group 1 category, with connective tissue disease accounting for the bulk of patients with PAH. And history of connective tissue disease was the strongest predictor of patients being diagnosed with PAH. Now, pulmonary hypertension can occur in valve disease, and that's one of the things we'll be talking about today in patients with aortic stenosis. It has an overall prevalence of anywhere from 15 to 30% at rest, but as high as 55% with exercise. Mitral stenosis is also a common concomitant risk factor for pulmonary hypertension, as well as aortic regurgitation and mitral regurgitation, affecting about anywhere from 30 to 62% of patients with mitral regurgitation. Now, most patients with valvular heart disease have very mild pulmonary hypertension. This is right heart cath data with the color coding defined as a mean PA pressure greater than 25. In the blue, the peach color, 35 millimeters of mercury, and the green color, 45 millimeters of mercury. And so what this highlights is that across the different valvular disease conditions, severe pulmonary hypertension is very uncommon, with most people having mild pulmonary hypertension. However, when we do see pulmonary hypertension in the setting of valve disease, it is something to pay attention to, as this can affect mortality and morbidity. This is all-cause mortality in patients who underwent TAVR at a single site, and demonstrating that the presence of pulmonary hypertension pre-op or pre-TAVR had a significant effect on mortality, and all-cause mortality as well as cardiovascular mortality on the right. Now, PH has been looked at in many of the different disease states, and in the general population, this is echocardiogram data breaking the RVSP or pulmonary arterial systolic pressure down by quintiles with 15 to 23, and then breakdown as the pressures go up. And what this demonstrates is that the higher the pulmonary arterial systolic pressure in the general population, the worse the outcomes, especially once patients get above 34 millimeters of mercury. And it doesn't matter if they have a history of cardiopulmonary disease or not, the higher the pressure, the worse the outcome, as well as in our heart failure population with either preserved ejection fraction or with reduced ejection fraction. And so pulmonary hypertension is a bad actor in most disease states as a comorbidity. When we look at patients with COPD, 90% of patients with severe COPD will have a mean PA pressure that's greater than 20 millimeters of mercury. And the pH is usually disease severity dependent, meaning that patients with mild disease usually have at most mild pulmonary hypertension if it's due to COPD, whereas moderate will have a moderate disease severity. 1 to 5% of patients with severe COPD will have a resting mean PA pressure greater than 35 to 40, indicating that although they may have a severe COPD, they usually don't have severe pulmonary hypertension. It's very uncommon to have severe disease. Usually it's in the mild category. And when we look at autopsy data, the vascular lesions that are seen in the pulmonary arteries are very similar to those with idiopathic pulmonary arterial hypertension. Interestingly, pH has a stronger association with mortality than even forced expiratory volume in 1 second. When we look at interstitial lung disease, mean PA pressure greater than or equal to 25 is uncommon as well, in only about 8 to 15% of patients with idiopathic pulmonary fibrosis. Although in advanced disease, about almost 50% of patients will have pulmonary hypertension. So it's usually mild in these patients. The mean PA pressure, however, usually increases at almost 2 millimeters of mercury per year. When we look at group 4 pulmonary hypertension or the CTEPH category, what we typically see is about 1 to 5% incidence occurring of CTEPH after a pulmonary embolism. And usually it happens within that first 2-year period. If, as this curve indicates the cumulative incidence of CTEPH, usually at 2 years, so about 3.8% of patients post-pulmonary embolism will have developed CTEPH. And if it happens after that, it's usually unrelated. 25% of patients in the CTEPH category will have no pulmonary embolism history. And we use a VQ scan, or ventilation perfusion scan, to detect CTEPH with a 96% sensitivity compared to CT, which is only about 51% sensitive. CTEPH is broken down into proximal versus distal disease. And the reason we break it down is because proximal can be often surgically cured or optimally treated. However, about 11 to 35% of patients will have residual PH requiring medications or have symptoms despite the pulmonary thromboendarterectomy surgery. And those patients we often treat with medications. In distal disease, usually there's medications that we use, especially anticoagulation in both categories, but also pulmonary hypertension directed medications specifically to address the elevated pressure. However, most recently, several big centers across the country and across the world, especially in Asia, are using pulmonary angioplasty with balloons to open up chronically occluded pulmonary arteries in the smaller branches, and usually doing this in successive procedures to prevent reperfusion injury and pulmonary edema, which can happen after this procedure. So they usually choose 1 or 2 segments at a time to do an angioplasty on, and then bring them back to the lab either a couple weeks later or a couple months later if the pressures and symptoms are still not optimally treated. When we look at the evaluation and workup, it's fairly extensive. Most patients undergo these basic screening tests with an echo, a VQ scan, pulmonary function testing, overnight oximetry, and then some labs, including functional test biomarkers such as NT-proBNP or BNP, and then a right heart cath. And these often lead to contingency tests to help with determining the best course of action in terms of what's causing the PH and also what's going to be most effective in treating it. And with these tests, we can then go on to develop a treatment plan. So echo is often our cornerstone in medicine for giving us a first telltale sign that someone may have pulmonary hypertension. Recall that normally the RV pressure should be low. The RV systolic pressure usually is less than 30. And we use that, we estimate it using the Bernoulli equation, which can sometimes be challenging if we can't, are unable to obtain an optimal TR velocity envelope, or if someone has torrential TR, may be inaccurate. And then, but we also can obtain very valuable data on the right heart function, looking at tricuspid annular plane systolic excursion, or how far the tricuspid annulus moves longitudinally, and then the S prime, which measures the velocity of that annulus, and then fractional area change of the right ventricle. However, right heart cath is really the gold standard, and the next test that we often do when we see elevated pressures. The new definition was recently updated last year, and now the mean PA pressure greater than 20 is the definition for pulmonary hypertension. And when we talk about pulmonary arterial hypertension, we're looking at the mean PA pressure greater than 20, with a wedge less than or equal to 15, and a pulmonary vascular resistance of greater than or equal to 3 Wood units. And then vasodilator response is often the next step if we haven't done the saline bolus or fluid challenge. and and at Minneapolis Heart Institute to use nitric oxide or nitroprusside, depending on the wedge pressure. Now we do the vasodilator response because it helps with figuring out which medications would be most appropriate. And as insurance companies are starting to have been balking at wanting to cover these PH medications, which can sometimes be expensive, they often throw up a roadblock with a vasodilator, needing a vasodilator challenge to determine the most appropriate treatments. And we define a positive vasodilator study as a mean PA pressure that drops by greater than or equal to 10 millimeters of mercury to a mean PA pressure less than 40 with either no change or an increase in the cardiac output. Now, historically, only about 1 in 10 to 1 in 20 patients have a positive vasodilator response, but it's generally a more favorable prognosis. And we generally treat these patients with calcium channel blockers as a first step. I have been able to participate in care of several patients who have been on calcium channel blockers for 20 to 30 years now, and that's the only medication that some of these patients have required. So it can be the patients that fall into the positive vasodilator category generally have a more favorable long-term prognosis. Now, with our hemodynamics, we can help decide which category these patients best fit in, and we can break them down into 3 categories: either pre-capillary pH, isolated post-capillary pH, or a combined pre and post-capillary pH. So with the pre-capillary pH, generally the PVR is elevated, the wedge is low, and the mean PA pressure is high. And that can be found in most of the groups besides group 2. And when we look at isolated post-capillary pulmonary hypertension, we're really talking about patients with predominantly group 2 pH, where the mean PA pressure is elevated, the wedge is also elevated, and the pulmonary vascular resistance is low. And then in patients with combined pre and post, they have, by definition, they have a mix of both pre and post capillary pH. So the wedge is high, the mean PA pressure is high, but the pulmonary vascular resistance is also elevated. And this is generally a category that is challenging to treat, as we have very few studies to hang our hat on in how to treat these patients. When we talk about the pathophysiology of pulmonary arterial hypertension, we're really talking about disruption of the pulmonary vasculature, change in the intima, as well as the media of the smooth muscle cells and the pulmonary arterial endothelial cells. And normally there's a nice balance between apoptosis and proliferation, with the lining staying nice and thin to allow for oxygen or oxygen and carbon dioxide diffusion in and out of the pulmonary arterial endothelial cells and arterioles as they wrap around the alveoli. However, over time, signals occur which lead to increased proliferation and decreased apoptosis, which leads to intimal hyperplasia, medial hypertrophy, inflammation, which then cascades further and to the point of becoming where the lumen becomes almost disintegrated, and you get these plexiform channels and an in situ thrombus forming, or a near obliteration of the pulmonary arterioles. Now, when we look at things schematically long term, what we typically see or don't see is patients in this New York Heart Association class 1 symptoms. Usually patients don't present to our clinics until they get into the class 2 or class 3 symptoms, and by then the horse is often out of the barn, with the PA pressure being significantly elevated and the pulmonary vascular resistance climbing, and typically starting to see the cardiac output drop, and this would highlight this would correspond with the 2.7 median years from symptom onset to diagnosis. I think we're all as a whole getting better at picking these patients up a little bit sooner now, and have a heightened sense of awareness of this disease state to starting to pick patients up down in this category. When we look at prognostic factors and risk predictions, there's historically pulmonary arterial hypertension. Most severe was the associated PAH or connective tissue disease groups, idiopathic PAH falling in the middle, and congenital heart disease with the most favorable prognosis. There was some thought that perhaps the patients with congenital heart disease had a more favorable prognosis with shunts, as the ASD or VSD could serve as a pop-off valve, and that led to the development of atrial septostomy as a potential treatment, especially in under or third world countries where resources and including pharmaceutical medications were limited. And so atrial septostomy has been demonstrated to be a viable treatment option in those areas, which we also use in end-stage pulmonary arterial hypertension as a bridge to transplant as well in the United States. When we look at long-term outcomes, the life expectancy and survival has improved. The 5-year survival was about 58%. The 1-year survival is very good, but we're still getting out to the 57% at 5 years and about 50% at 7 years. When we look at prognostic factors, there's a REVEAL risk predictor score, which was developed by Ray Benza of Allegheny Health System in Pennsylvania. And one of those inclusion criteria for the risk predictor is a pericardial effusion. Pericardial effusions develop in pulmonary arterial hypertension and can be a negative prognostic indicator. Pericardial effusion, typically fluid within the pericardium is regulated tightly with lymphatic drainage back into the coronary into the venous system, coronary sinus, and a high right atrial pressure seems to be the stopgap for this drainage. And when the right atrial pressure is elevated, pericardial effusions will develop, and the size of them makes a big difference. And so this demonstrates in 577 patients that no pericardial effusion has a more favorable prognosis long-term, whereas a small pericardial effusion or moderate or greater pericardial effusion has an impact on mortality. When we look at other things that we do in our clinics, such as EKGs, right atrial enlargement has a prognostic indicator when it's present on EKGs in patients with PAH, as well as right ventricular hypertrophy, also demonstrating a prognostic indicator and an impact on mortality. So to segue into some of the research that we've been doing at Minneapolis Heart Institute, we're going to talk about one project that was started several years ago in looking at rural versus urban patients who have pulmonary hypertension, and this really started with echo data actually in our clinics and highlighting patients who had elevated RVSPs and then working them up and then creating a registry. And so we have a registry now in our clinics up north, which are in Baxter, Brainerd, Crosby, and Aiken, which is these counties in central Minnesota that serve about a 60 to 120 mile radius, and sometimes even longer or even more distant than that. But different demographic and socioeconomic pressures affect rural communities versus urban communities. About 1.4 million Minnesotans live in rural areas, including in the area where I serve. And then there's a lack of access to specialist physicians with about 30 specialists per 100,000 patients in rural communities versus about 263 specialists per 100,000 patients in urban areas. And so with that, we raised a couple of questions looking at PH registries historically that are heavily weighted to urban populations across both the United States and Europe, and then looking at the classification and prevalence in rural areas and suspecting that the PH is likely underreported. We did a retrospective review of consecutive patients with elevated RVSPs, either greater than or equal to 50 millimeters of mercury, or if they were referred to our cardiovascular clinic with PH symptoms. We defined PAH as a mean PA pressure of greater than or equal to 25, with a wedge less than 15 and a PVR greater than 3.0 Wood units, which is the old definition reflecting that this study was started a couple years ago. And we looked at consecutive patients from August 2015 till October 2018. And what we found was that we had 99 patients in that group, and went through and looked at different patient characteristics. And what we found was that there's a 50% male to female ratio. It's an older population with an average age of 73. The BMI was 32, indicating obesity in both groups, but no difference in within the group 1 versus non-group 1 PH. With age, the group 1 or PAH group tended to be, or was younger with an average of age of 66 versus 73. Atrial fibrillation occurred in 50% of the population, but tended to occur more commonly in the non-group 1 PH. And 6-minute walk distance was also different between groups, with the PAH group only able to walk about 246 meters on average versus 289 meters in the other group, with a high notable range within each group, ranging from 82 meters, which would be a very severe low distance to walk in 6 minutes, versus 527 meters, which would classify as an Olympic track star in the PAH groups. When we look at echo characteristics, what we see is that the right atrial pressure is elevated amongst both groups with no difference. RVSP, no surprise, was a little bit elevated, more so in the PAH group. Ejection fraction was also a little bit higher in the PAH group, and left atrial enlargement occurred more commonly in the non-PAH group. No surprise. When we look at right heart cath characteristics of the two groups, a few things to highlight. Would be that right atrial pressure tended to be lower in the PAH group, while RVSP was elevated, was higher. The mean PA pressure was also higher at almost 45 versus 35 in the non-PAH group. The wedge, no surprise, was also lower in the PAH group. Cardiac index, no different between the groups. When we look at prevalence of PH in rural Minnesota, this is where I thought things were a little bit interesting. So our our counties that we serve, I broke it down into the majority of the patients lived in Crow Wing or Aiken County, which are highlighted here, with Crow Wing County being above here and Aiken County being below. Population of both counties, with the county that has, or Crow Wing County, which has Brainerd and Baxter, is about 62,500 versus Aiken County at 16,000. So very sparsely populated counties. Crow Wing County, when we calculate the prevalence of pulmonary hypertension, we find that it occurred in a frequency of about 124 per million if we extrapolate out to 1 million people, whereas the PAH occurred in about 196 per million. And then if we look at Aiken County, what we estimate is about 631 cases per million versus prevalence of PAH at 638 per million. Now this is population data specifically only to the two counties that we looked at. I haven't looked at Cass County yet, but would suspect that there's a common trend there as well. And so many, so much more pulmonary hypertension than I would have anticipated. As of date, our registry is ongoing and continuing to identify patients, and we're up to 261 patients total with various forms of pulmonary hypertension in our area. What we see is that there's about a 2.5 to 13 times higher than estimated prevalence in PAH when looking at national data and international data. And the question is why? Does it have to do with lower socioeconomic areas? We have patients in this area that don't have access to basic necessities such as running water or electricity, some that live in the woods and maybe haven't seen a doctor since the day they were born or their last immunization. Is it due to environmental exposures? There's a heavy mining community, or used to be a heavy mining community in this area, which I suspect probably isn't the case, as a lot of these patients are transplants from the Twin Cities who retired up to the Lakes country. Or is this just a national trend of under-recognition, which I suspect it is. So when we dive into the other research project that I was working on, looking at patients who underwent TAVR, we know that patients with aortic stenosis, when they have pulmonary hypertension, it can impact their 1 and 2 year survival, and that many patients, despite having the TAVR, don't normalize their right ventricular systolic pressure or PA pressure. And so we did a retrospective review through the Minneapolis Heart Institute Foundation Research Internship Program, looking at patients with TAVR who underwent it between 1/1/2009 to 4/29/2019. And all these patients had pre and post TAVR echoes, as well as pre-TAVR right heart caths. And we defined pH using the updated definition with a mean PA pressure greater than 20 millimeters of mercury. And we defined residual pH as an RBS, took a very conservative definition and defined it as an RBSP greater than or equal to 50 on their post-TAVR echo, because most patients did not undergo a post-TAVR right heart cath. So our patient population started with 268 patients, and after whittling it down due to incomplete data, we had 153 patients that had post-TAVR echo with an elevated RBSP. And we found that 153 patients that had pre and post TAVR echoes and right heart cath, and we had with elevated RBSP on their pre-TAVR echo, and only 28 patients had residual pH defined by the RBSP elevated at 50 or higher, versus 125 that normalized their right ventricular systolic pressures post-TAVR. So that accounts for about 18% of our patient population that had residual pH. And when we look at patient characteristics, no surprise, there's about a 50-50 breakdown between male and female. The only differences between groups in patients who had post-TAVR pH versus normalized RBSP was sleep apnea occurring in patients that normalized their RBSP. Otherwise, the groups were the same. As no surprise, coronary artery disease and atrial fibrillation were ubiquitous between the two groups, occurring in almost everybody. Frailty, STS risk score, prior valve surgeries, no difference between the two groups. When we look at right heart cath hemodynamics pre-TAVR and break it down into those who had residual pH afterwards, which is the red group, versus normalized or no PH post-TAVR, which is the purple group. What we saw is that those who had PH after TAVR tended to have an elevated RVSP, a higher mean PA pressure, higher pulmonary vascular resistance, approaching above 4 versus just above 2, and a higher transpulmonary gradient defined by the mean PA pressure minus the wedge. When I looked at the hemodynamics, the pre-TAVR right heart cath, 10 patients would fit neatly within the group of PAH, whereas 130 patients had hemodynamics that would be consistent with either group 2 or group 3 pulmonary hypertension, either due to intrinsic left-sided heart disease or lung disease. 4 patients had incomplete data, and 9 patients did not fit the criteria for PH. Now, 9 patients underwent post-TAVR right heart cath, and so I looked at those hemodynamics and included them here as I think they're interesting. There are, several patients who had elevated PVRs, such as patient number 2, whose PVR was 7.25 Wood units. But when we look at the hemodynamics, they would have this would be classified as a pre and post capillary combined pulmonary hypertension with an elevated wedge of 19. Likewise with this patient here, number 5, who had a mean PA pressure of 48 and a wedge of 18. This patient also would fit into the category of a combined pre and post, and then patients such as number 6, which looks consistent with a group 2 pulmonary hypertension. And so when we looked at the patients with residual PH, 1 patient was on pulmonary hypertension medications, and the remainder weren't. In most cases appropriately so, because we don't know what the optimal treatment of choice is for patients with combined pre and post PH. When we look at echo data after TAVR, what we see is that the majority of patients have a RVSP less than 40, whereas about 18% have a RVSP between 40 and 49, and then 18% with RVSP greater than 50. And what we find is that these patients that fall into this latter category of RVSP greater than 50 tended to have a lower aortic valve mean gradient pre-TAVR, and really didn't make any changes post-TAVR on their with their RVSP, with only about a millimeter change pre and post-TAVR in that group. Now, pulmonary hypertension, as highlighted, has an impact on survival from other studies, but what we also found out was that these patients with residual pulmonary hypertension tended to be hospitalized in significantly more than patients that resolved or normalized their RVSP in almost a 3-to-1 ratio. So 39% rehospitalizations for heart failure versus 14% in the non-PH group. And so this highlights that perhaps these patients we should be watching closely to try to help lower hospitalization. When we look at predictive factors for post-TAVR PH, what we see is that patients with moderate to severe right ventricular enlargement, as well as moderate to severe RV dysfunction, were more likely to have post-TAVR pulmonary hypertension. Pericardial effusion, right atrial enlargement also were highlighted here, but non-significant. When we look at likelihood ratios, the higher the RVSP, the more likely someone would have post-TAVR PH. Likewise, moderate severe RV enlargement, pericardial effusion, pulmonary vascular resistance greater than 4 Wood units, elevated and as the transpulmonary gradient increased, the likelihood ratio increased as well for post-TAVR PH. And likewise with mean PA pressure on the right heart cath, that was pre-TAVR, the higher the mean PA pressure, the more likely someone would continue to have PH after TAVR. When we look at survival, what I think is interesting here is that the curves are very similar up to about 1 year, and that's when they start to separate. And there is a significant change with greater than 50% mortality at 2 years in the group that has pulmonary hypertension and doesn't normalize their RVSP post-TAVR. And so take-home messages from both the on pulmonary hypertension as well as some of the research that I've been doing, just to reiterate that there's 5 groups of pulmonary hypertension. Group 1 is PAH, which is the group that we have medications for. Right heart cath is the gold standard for diagnosing. It can be very helpful to figure out which medication is going to be most effective and appropriate. Pulmonary arterial hypertension, new definition, is a mean PA pressure greater than 20 millimeters of mercury with a wedge of less than or equal to 15 and a PVR greater than or equal to 3 Wood units. From our research, it appears that PAH may be a little underreported in the rural population compared to the urban population from different registry studies. And I think part of that is probably access to care, where patients in more rural areas have troubles getting to the tertiary and quaternary referral centers. And then when we look at post-TAVR pulmonary hypertension in our MHI population, it occurs in almost upwards of 20% of patients, which would go along with other studies, including a study published by Dr. Cavalcante a year or two ago, and falls within the expected range for what we would expect. It's associated with heart failure hospitalizations in those patients that are post-TAVR with residual PH, and it also has an impact on mortality. With that, I'd like to thank the Minneapolis Heart Institute Foundation for continuing to support the research studies that we're doing up in the Baxter-Brainerd area, as well as the research interns that have worked on these projects, Chris Gitter, Nicole Bonfig, and Lily McCaffrey. The excellent statistical work by our statisticians, Larissa Stanberry, Ross Garbarich, and then our excellent study coordinators that have groomed the research interns and also helped with some of the study data. Specifically Stephanie Ebnet and Sarah Schwager. And then my colleagues Peter Stockman and Tim Dirks for putting up with my passion and obsession for pulmonary hypertension. And with that, I'd like to open things up if there are any questions.
All right, thank you, Dr. Fenstad. That was a great presentation. And like we said, we're open up for Q&A right now. So please access that Q&A pod located at the bottom of your screen. And feel free to enter any questions or comments. And we'll give it a minute here. All right, well, so far there's no questions or comments yet, but we just, again, like to thank Dr. Fenstad for his presentation. It looks like we have a hand that is raised. Again, just a reminder, please access the Q&A pod located at the bottom of your screen and type in your question, please. All right, well, it looks like there's no questions. Oh, looks like we just got one. So why the change in the definitions for pulmonary hypertension mean 25 to 20?
It's a great question. So it has to do with the standard deviation for PA pressures, and historically 20 millimeters of mercury was 2 standard deviations above the normal for PA pressure, and pressures between 20 and 24 used to be labeled as gray zone pressure, meaning kind of no person's land, where we weren't sure what to do with it. They didn't quite fit nicely into the pH definition, yet were greater than 2 standard deviations above normal. And so the big change by the experts was to move that definition down, kind of like what experts have done in endocrinology with changing the definition of diabetes. Now the 20 represents 2 standard deviations above normal for the PA pressure.
Excellent, thank you. Well, I think that's all we have for comments and questions. I'd just like to say thank you everyone for joining us. Thank you, Dr. Fenstad, for presenting. Please tune in next week for Drs. Bradley and Garcia. They're presenting on the National COVID-19 Cardiovascular Registries. Dr. Fenstad, do you have anything else that you'd like to say?
Thank you, everybody.
All right, thank you.